I think the joint space is okay. I
Okay,
think it's, and remember in the exam, anything you say, you have to back up, be able to back up.
I
Yeah.
see. Yeah.
So just be really sure of any statement you make, you may be probed further.
Uh-huh.
Stick to what is definitely there. So you've got widened epiphysis, and you've got the Klein's line is not Klein's line rather is not going through the epiphysis. So it is a slipped upper femoral epiphysis.
Okay.
And what can you do to confirm this?
We do a frog leg view.
Yeah, I mean, to be honest, I don't think you need to because it's diagnostic this. But if you just scroll down with your mouse,
Yeah.
it should bring up this, or you can just bring it up. Yeah, that way. There you go. That's a frog leg view, isn't it? If you scroll down with your mouse, it'll appear.
All right.
Scroll down.
Yes.
There we go.
Yeah.
So there you can see quite nicely how that epiphysis has slipped posteromedially.
Yes.
Now, what is the treatment for this condition?
I think it's conservative, as in like rest and.
No, it's not conservative because it'll just stay like that then and then have a deformity for life.
All right. So,
They need
so
it pinning.
yeah.
They pop a pin in there. How many of these are bilateral? How many of these cases occur bilaterally?
Is it 10%?
Yeah, good guess. So 20 to 10 to 20%.
Mm-hmm.
And sometimes they prophylactically will pin the other side too, just to
Right.
make sure that also doesn't slip. And what do you expect demographically this patient to look like, age and that kind of thing?
Peri-teenage, a bit of an overweight teenager.
Yeah,
Um,
usually it's boys, this is girl, and they might come with a limp. That's usually the presenting complaint.
I
So
see.
this is Sufi, a nice case of Sufi.
Yeah.
Any questions? And as I say, feel free to ask questions. I'll be checking the chat box if anyone's got any questions. But Reem, do you have any questions about this?
No, thank you.
Okay,
Yeah.
here's another case then. So again, if you just come back to the chat box, I've just pasted another link, and I'm hoping it will just appear like magic.
Um, um,
Our mystery guest is commenting in the chat box. Not very mystery because he's got his picture on there.
right.
Yeah. So you can window this a bit. It always, for some reason, comes up like this. So do you know how to window on Paxspin?
I think I do. Yeah.
Yeah,
Uh,
it's just that one. Yeah. Yeah. So patient presents with swelling in the hands.
yes. So this is a DP view of a left wrist and hand. Um, there are multiple lesions. It's quite abnormal actually, and there is multiple lesions in the phalanges. So in the small um, phalanx, proximal phalanx, there is a destructive appearance with a soft tissue component.
So
Um,
just window it slightly more because to me it's looking really dark. I think you can make this a bit brighter, which will make it easier for you.
just that, am I going in the right direction?
Um,
Uh,
no. Oh yeah, yeah, that way. So brighter up
okay, yeah,
north a bit. North, keep going north, keep going north. There
yeah,
we go. There
yeah,
we go. Now just stop around there, I think.
hmm,
Okay. That
yeah.
is where one of the abnormalities is. So, and I know it's blurry for some reason, but go on.
Yeah.
You tell me what you think it is.
So there is another one here in the middle phalanx, sorry, in the proximal phalanx of the middle finger. And I also, sorry, I'm meant to move the, sorry, I wanted to lift up the image, so I'm just scrolling through the other images. Um,
Okay.
there's other views. Am I allowed to look at it?
You can, but I don't think you're going to get any more information from them. So you can just concentrate on this one.
Okay, so these are multiple bony lesions in the proximal phalanges with a soft tissue component, and they have like lytic pattern to them. They're not expansile to the bone, but maybe this one is. So I wonder if this is gout. Other thing that I'm thinking about is psoriasis. Um, and I would like to correlate it with any history.
No history except swelling of hands. Now, gout is the diagnosis in
Yes.
this, okay?
Yeah.
But your description, I want to just analyze that a little bit. So you said that there are lytic lesions. So to me, when you say lytic and when you say lesion, that to me sounds malignant and aggressive.
I see.
Whereas we know gout isn't it? So it's about using the right language as well.
Hmm.
So they're erosions, aren't they, in gout? And they're
Yes.
and you need to, as with any condition in radiology, really, like there's buzzwords, isn't there, associated, which are like synonymous with the diagnosis.
Yes.
So buzz terms are buzzwords. So with gout, it would be juxtaarticular, um, punched out
Erosion.
erosions with sclerotic edges.
Hmm.
Okay. And then the soft tissue swelling you're seeing, what is that then if they've got gout?
It's the typhi or
Tophi, yeah, the tophi, and that's typically dense swelling of the soft tissues, which is exactly what this is. So I would, again, this is just a tip for you because you got the right diagnosis, but I would just be really careful with the description you're
yeah.
giving,
Hmm.
because it almost like was implying that you were going to call this something malignant, but so lytic, and if you want to call it if something lucent, to me that's like a less aggressive
Yeah.
um, term to use. But for me, lytic means destructive.
Yeah.
Um, so yeah, juxtaarticular, well punched out, sclerotic edges, overhanging edges, and usually you see it in the foot, don't you? But you can get it anywhere, and you can get it in the hands, as is seen here. And so this is, and now psoriatic rather, was your other differential.
Yes.
You wouldn't really get the swelling, the soft tissue density with that. And I think the erosions are not typical for that condition either.
Right.
Um, I think maybe I'm thinking you said that because you're thinking maybe that looks a bit like pencil and cup.
Yes, and
Maybe in the fifth. Yeah, which I sort of know what you mean, but actually, again, and I apologize for the quality of the image, I think it's just the windowing's not quite right. Um,
I
the
think I
tip
was,
is not actually eroded, as in the head and articular surface of that fifth proximal phalanx is not actually eroded as it would be in pencil and cup. It's a
yeah,
very much like the articular surface is kind of preserved. It's the juxta-articular bit which is eroded.
yeah.
So this is gout.
Mhm.
So this is a case of like, so in the exam, one of the kind of types of cases you may get is a common pathology but an uncommon place.
Yeah,
So this is an example of that.
I see.
Okay,
Yeah.
I have another case for you.
Great.
Uh, is that the same one? No, it's a different one.
Yep.
Hook-like osteophyte, someone's, whilst you're just loading that up, I'm just going to answer some of these questions. No, I don't think there's hook-like osteophytes. You get that in hemochromatosis, don't you know? Um, Osteopenia, reduced intercarpal and PIP joint space and soft tissue nodules can give differentials as RA. Yeah, but I don't think, I mean, they had generalized osteopenia. It's not very periarticular, which is what you see in RA. And again, those erosions are not typical for RA, so I wouldn't really give RA as a differential. Again, in the exam, sometimes there is just only one diagnosis and not many differentials. Okay, so I would say that, and always remember, I sort of have a rule, which is have three differentials for most things, unless, as I say, it's very clear what the diagnosis is, and always start with the most common, as in don't start saying something totally uncommon, irrelevant. Yeah, that makes sense, doesn't it?
Yeah.
Okay, here we have a CT abdomen pelvis, and this is a 25-year-old young woman who is presenting with acute abdominal pain.
Right. Um, so I'm presented with a axial CT, abdomen and pelvis, with IV contrast in the portal venous phase, of a young patient. Um, what caught up my eye immediately is the free intraperitoneal fluid, tracking both paracolic gutters, and mostly noted around the spleen on the left side, but it also tracks all the way to the pelvic area. Um, right here, I can see this bulky uterus as well. I'll just take a few seconds to see where is this fluid coming from and what could be the cause.
Yeah, sure.
Right, I can't see particularly any like an enhancing lesion on the right side to suggest an appendicitis because initially I thought a young person with some fluid could be
Yeah,
appendicitis, but this is
yeah.
all looking
Good
at.
thought. Okay, I'll walk you through this case. Okay.
Okay,
So, number one thing is there is fluid. Now, the second thing is what type of fluid is it?
yeah. So I'll measure the Hounsfield units.
But I think you can see this with just eyeballing it.
I think
Down
it's
in the pelvis, does
yeah,
it look
it,
dense?
it is dense, and I think it is coming from the uterine area because the
Okay.
uterus is also very dense. So I would like to, if there is one question I would ask is, did any pregnancy test take place? And if
That's
there,
a really good question because why do you ask that?
because I am now suspicious that this is maybe a ruptured ectopic pregnancy.
That's an excellent differential. And a pregnancy test was done and it was negative.
Right. So my second differential would be a ruptured ovarian cyst or a twisted ovarian
Okay.
cyst.
Okay.
Mhm.
Okay. What do you want to do next?
So what do I want to do next? I
Hmm.
think I would do a delayed phase to see if there is any bleeder down in the pelvis.
No,
Um,
because we don't think this is vascular, do we? We don't think this is a vessel. Nor do we think this is like coming like a delayed phase, like a bladder rupture. Yeah, as you pointed out there, the uterus is quite prominent, but actually, if you look in the left adnexa, what's all that swirling going on there?
yeah,
There's
yeah,
lots of like mixed blood products there, and that's where it's coming from. And I think that's pretty much as far as CT can take you, as you know, with
yeah,
CT is not the best modality, is it, for pelvic organs? So
yeah,
what you could now suggest is now entirely depends on the clinical state of the patient.
yeah,
And this is a chance for you to show off that you're a clinical radiologist
yeah,
and not just a radiologist. And so you can say, look, if the patient is stable, they could consider doing an MRI or an ultrasound, and that will give them better detail of the pelvic organs and what's going on there. But
yeah.
actually, this patient was quite hemodynamically unstable because they're just bleeding out into their abdomen. And so she was taken to theatre, and it was there where, after the histology, everything, what they'd taken out, it was a ruptured corpus luteal cyst.
I see.
So that's not, I don't expect you to know that for looking at the CT, as I say,
Hmm.
but there's something going on in the pelvis, and your differentials. I wanted you to say ectopic, and it's excellent that you're asking again. You're thinking outside of the box and asking about the clinical kind of side of things, which is has a pregnancy test been done or not? And then the second thing would be a ruptured ovarian cyst, which is what this was, corpus luteal cyst specifically. Um, and this is just a lesson in, because I think people sometimes forget gynecological emergencies.
Yeah,
Um, and this is an example of that. And it's just to make sure you don't always need the ruptured corpus luteal cyst outside a positive pregnancy test. I'm just reading the so, yeah, so it's just a type of cyst, isn't it? Which has ruptured and then they're not pregnant. Okay, so that's your case of CT, of hemoperitoneum. So let's show you another one.
okay.
So this is a CT head, and you can just put that into brain windows because I think it always comes up in bone windows from something. Yes, Dr. Zophine Khan, ruptured corpus luteal cyst with so much hemoperitoneum, very, very unusual. Unusual, but it happened, yeah. So yeah, just pop it into the brain windows.
Yeah, okay. So this is an axial CT of the brain in a soft tissue window right now. Um, so what caught up my eye immediately in this is um, this a hypodensity in the left frontoparietal area. There is also this lesion that is hyperdense. in the left also frontoparietal area, and it has a wide base of attachment to the dura, and it's homogeneous, and there is like a rim of calcifications in the periphery of it.
Yeah.
I think this is like my first differential for this lesion would be a meningioma. Just evaluating the rest of the CT, I think the ventricles are patent. There's no hydrocephalus, and also there's no crowding in the
Yeah.
yeah, in the foramen magnum. Um,
So
is
if you put it into bone windows, are there any more signs there which make you more confident that this is a meningioma?
So the peripheral calcifications is what, and also yeah, there is a bit of hyperostosis here, which
Yes.
is something that meningioma does as well.
Yes. Yes, exactly. So yes, you're exactly right. This is a meningioma. It's quite large and it's causing some degree of vasogenic edema. So if you put it back onto brain windows,
Yep.
um, so it is causing some mass effect, isn't it, there? Just because of the size of it. He's probably had it a long time. It's just slowly growing away. But and sometimes they can, I mean, they're benign, the majority of them, so they can just be left alone usually. But I think this one's actually causing mass effect. So I believe this one was resected
Right.
and hopefully that vasogenic edema then resolved.
Mhm.
But yeah, you described all the features there of a meningioma, and I think again this would be like an opening case, just a starter to get you comfortable in the Viva seat. Okay, here's
Okay.
another case.
Yep. Right. So this is a frontal chest radiograph and a posterior anterior projection of an adult patient. And what catches my eye immediately is this a well-defined oval opacity on the right, mid to lower medial zones. Um, I can appreciate the heart border separate to this mass, as well as the right hemidiaphragm. And I can also see the right hilar it can be appreciated separate to this mass, which is the hilum overlay sign. So this is not in the anterior mediastinum, this mass, and it's not in the it's not in the anterior mediastinum. The rest of the lungs are clear. There's no pleural effusion, and I'm just quickly glancing the bones, and I think the bones are fine, just grossly. So about this mass, it looks like it is in the posterior mediastinum, most likely. And I would like to correlate it with any history of the patient and why did they have this chest radiograph.
It was relating to some shortness of breath the patient had.
Right, okay. So with
So
my,
go
yeah,
on, go on.
I well, with the hilum overlay sign and with the heart being appreciated separate to this mass and its
Yeah.
posterior, I would
Yes.
put like the neurogenic tumors on the top of my differential
Yeah.
because yeah, they're very common. Um, but then it could also be some like an enteric cyst next to the esophagus or uh,
Possibly.
yep. What I would do next is I would advise for a CT thorax to just
Yes.
go a bit further. Yeah.
Yes. So remember again, now if we just pause there. So anytime you'll usually be given an X-ray first. And um unfortunately in today's world, and I'm the same really, I just when I see an X-ray like this, I'm already thinking about the CT. So I don't really spend too much time because I know that's what's gonna happen next.
Yeah.
But that in the exam they want you to get as much information as you can from this radiograph. And you pretty much, we've already said that we think it's mediastinal and we think it's in the posterior mediastinum, and I entirely agree with you because you can see the heart border, as you said, therefore it's not in the anterior mediastinum, and you can see the hilum overlay sign, therefore it's not in the middle mediastinum. That only leaves the posterior mediastinum. Then I want you to rattle off three differentials, which again, and by the time you come around to the exam, you won't even have to think about it. But your
Mhm.
first differential was neurogenic lesion, which I like. I like that as a first differential. What kind of lesions are you thinking of? What
Um,
specifically?
so neurofibroma or neuroganglioma,
Neuroma, yeah, or schwannoma.
neuroganglioma, yes. So,
Schwannoma, yeah, yeah.
so
So
left listeners,
yeah,
yes.
and then of course once you've exhausted everything you can from the chest X-ray,
Yeah.
you say obviously they'll need cross-sectional imaging, they'll need MDT referral, they'll probably need tissue diagnosis.
Yes.
So this turned out to be a schwannoma, and this is a youngish lady, and it had just been growing. And I don't think you can appreciate it very well on the X-ray, but there is some rib notching, because it's just grown slowly, gradually remodeled the ribs around it. What would be the top three differentials for posterior mediastinal mass? So neurogenic tumor, or it could be benign or malignant.
Mhm.
Extramedullary hematopoiesis,
Yeah.
but you expect more masses than just one solitary mass, like a cyst, as you said, like uh, even a duplication cyst or one of these things. And then lymph node again, not going to doesn't look like that, does it? One large lymph node, not going to look like that.
Mm.
Um, that's more than three, isn't it? So, yeah, those would be my differentials.
Mm.
Solitary fibrous tumor, possibly. Yeah, if you throw that in there, I don't mind. Meningocele, yeah, that's a good one. So I like these offerings people are giving us here.
Yeah.
Anyway, this was a schwannoma. It kind of, uh, and here we go. The mystery guest, NF, cyst, rarely lymphoma. Yes, I like all of those. Okay. Um, So mediastinal masses, this comes up again and again and again, right? It's one of the like first concepts you get taught in radiology, don't you? And it's the same thing that just gets repeated. But by the time you come to the exam, you need to be really slick with it. I'm
Okay.
not saying you, Reem, I'm saying everybody needs to be really slick with it.
Mhm.
And yeah, but yeah, you came to the right diagnosis there. Let's give you another one. For some reason the X-rays always take longer to come up, and then the windowing's always a bit off.
Yeah. Um,
Try
yeah.
and just manipulate it so yeah, that looks better. It's just a bit blurry. Maybe that's your internet connection actually, the
Oh, is it?
blurriness. But everyone else can look at it and on their own screens anyway. So
Yeah.
anyway, that's better, isn't it?
Yeah. So this is a frontal radiograph of of a pelvis of an adult patient. What catches my eye immediately is this multiple sclerotic lesions that are in the left hip, left femoral bones bilaterally. I can see them in the neck of the femur on the left femur, as well as milder features of the same changes on the right femur. Also, both the superior and inferior rami of the pubis are a bit dense and they're sclerotic, or they look
Yeah.
sclerotic to my eye. Um,
Yes.
so this is multiple sclerotic lesions,
Yeah.
um, in a patient. Am I all right to think this patient is a male?
Yes.
Yes, so I think the first differential that I would think of is this a metastatic prostate cancer?
It
And
is.
okay, so then I think I would discuss my findings with the clinicians, and if it's not diagnosed already, I think this patient would need prostate imaging
Yeah.
and workup
And
discussion.
what else can they do to find out if it's likely to be prostate CA clinically?
Well, they can first examine the patient, obviously, but then
Yeah.
also the prostate specific antigen as a
Yeah.
blood marker, and if it's
Yes.
elevated, that supports the diagnosis, I guess.
Yeah, but I mean, it is prostate cancer, isn't it? So, but yeah, like just again, just to show off your clinical knowledge, you can say that
I
in
see.
the exam.
Yeah.
Yeah.
Mhm.
So prostate mets, any differentials?
So things that would increase the density of the bone, like um, is it hypoparathyroidism? Sorry, I'm trying to think.
There are a few conditions,
Yes.
but they kind of diffusely increase this density of your bones rather than giving you patches like lesions like this. Paget's, again, no, it won't look like this, will it? Because um, You get
Geographic.
the like, yeah, you get like the coarsen trabeculae and the in the expansile bone, and so again that won't look like it. Myelofibrosis, I think, does that give you just increased density? Osteopetrosis gives you increased density throughout, but again, this is one of those cases where it is prostate mets and nothing else really. Osteoporosis, no, I don't think so, because you get those little small sclerotic areas, which are like little dots, but no, I wouldn't say so. So I think this is one of those cases where it is just that.
Okay.
Okay.
Yep.
Um, osteochondroma, no, definitely not an osteochondroma. So I put another case in there.
Okay. Is this the one before the
Yeah,
okay.
yeah.
All right.
Okay,
So
so let me tell you about this a little bit. This is a scout from scout view of a CT, which is a CT pan scan for a trauma, major
mhm,
trauma.
yeah.
So I work in a major trauma center,
Mhm.
and I don't know if you've got much experience of trauma scanning,
Yeah.
Newcastle.
Yep.
Yeah.
Yeah.
So tell me about the protocols that's like used as a standard for trauma scanning.
So I think the very recent guideline says that the scanogram has to include the whole of the body until the toes, because then we have to know whether there is any distal fractures, for example, and then we can decide, um, um, are we going to go all the way with the actual axial slices, or just stop at a certain level? So I
Yeah.
think the scanogram is not sufficient according to the new guidance.
Yeah. Okay. Well, this is quite an old scan. So, yeah, that's fair. But what
Yeah.
about the scan itself?
The scan itself, right?
Talk to me about the protocol.
Oh, so we do like a
It's got a
bolus.
name.
Yeah, yeah. It's a dual bolus contrast study. So we
Yeah.
put both arterial, and we basically capture the images at both arterial and venous. And how it works is we give a contrast. We give the contrast. Wait 75 seconds, and then just before the 75 seconds, by like maybe 20 seconds, we give the other bolus of contrast. So we capture the images on both arterial and venous
Yeah. So that's for the abdomen, right?
yeah, yeah,
So I'll tell you what we do in Aintree, which is where I work, and
right.
it's pretty much, maybe it's a slightly modified protocol. What is the name of the protocol that is used in standard for trauma scanning?
Do we not just call it trauma
Yeah.
protocol? Yeah.
No. I'm saying yes. I'm saying yes to the person who's put it in this chat. Bastion, Camp
Um,
Bastion protocol.
Bastian,
So,
right. Okay.
oh, sorry, no. I want you to keep looking at that case. Sorry.
I'm sorry. Okay.
It's come up. We haven't got to the answer
I'm
yet.
sorry.
We haven't got to the answer.
Right.
Um, Camp Bastion, camp in Afghanistan, I believe, military camp, and that's where they developed this protocol. And it's pretty much a screening scan for major traumas, because traumas are coming through so fast that you can't waste time just doing an arterial and a portovenous separate for each patient. So this way, it saves time, it saves radiation.
Right.
Irradiating the patient, because otherwise you have to scan them twice.
Mm.
And it kind of gives you an overview as to if there's any injuries. The only problem is if you then see like a vascular injury of contrast blush, then how do you know if it's arterial or venous? Well, you don't sometimes. So then you
Yeah.
have to end up doing the delayed phase anyway.
Mm.
But how we do it, we do a unenhanced head. Some places do an unenhanced C-spine as well, which I prefer, because then it reduces the artifact from the vessels, the contrast in the vessels. But we've changed our protocol recently. So now we do an arterial neck and chest.
Mm-hmm.
Okay.
Mm-hmm.
And then we give that second bolus, and then we scan uh, the abdomen and pelvis.
Mm-hmm.
So one bolus is in the arterial phase, and one bolus is in the venous system, arterial system and venous system, and then you
Yeah.
get a picture of both together.
Mm-hmm.
And then, as you say, sometimes if clinically they want the limbs doing, we'll do that too. So that's the Camp Bastion protocol. Now, how would we, when we just do a normal CT chest, like say it's an outpatient setting, whatever,
Mm-hmm.
how is the patient looking to you?
Um,
How would they look?
in like in the CT,
Yeah, what's the position? Yeah.
the hands should be like both of them lifted up. So
Yeah.
yeah, so to avoid
Yes.
any artifacts from the
Yeah,
yeah,
usually we try and do that, don't we? Because it actually really reduces the streak artifact, doesn't it?
yes, yeah.
That you see. But in a trauma setting, major trauma, are you gonna bother doing that?
No, because
No,
sometimes it's a position that they cannot help.
exactly. And plus they might be moribund, they might be, not conscious, whatever. So
Yeah.
um usually we just scan them as they are, right, with their arms down. But obviously what is different about this patient?
It's the left arm is on like down and also on the like on the abdomen.
Right. So right arm is up
Yeah,
and
right
left arm
arm.
is down.
Yes.
So it's a bit of an unusual appearance if you just imagine seeing them. So again, you know, imagine looking at them from the end of the bed. They'd look quite strange. So what is going on there, which is causing him to look like that?
I think I know. I think it's this here. There is, oh my God, there is like an inferior shoulder dislocation.
And what is that called?
It has a name. It's inferior. It's I'm sorry, I promise I read it before.
Don't worry. Don't worry. And again, right, if this happens in the exam
Yeah,
where you just forget the name, it's normal. It happens. I if it was me, the examiner, and I know you know what it is, you just
yeah,
can't remember the name, I would still give you the points, you know? So
that,
don't
okay.
worry if you just if the words just slip from your mind, it's okay.
Yeah,
But there's people who got it right in the chat, which I'm really happy with. So luxatio erecta.
that's it. Like,
It sounds like a Harry Potter spell. And that's what it is. So basically, it's a really rare form of shoulder dislocation where the shoulder goes inferiorly. And this was, I think, a motorcycle accident. So it must have been a major trauma. He must have landed on his shoulder and it's gone inferiorly, and he physically cannot put his arm down
right.
because of this type of dislocation. So this is again, you may get shown something like this, and this is kind of thinking outside the box a little bit, isn't it? It's like, well, what's unusual about this patient? Why would they look like this going through the scanner? And it's
Mhm.
because he can't put his arm down.
Yep,
And you can make that diagnosis off the scout, which
yep,
is quite good, isn't it?
yes.
So that is your half an hour, Reem.
Well, thank you.
How do we do feedback? I don't know. We're kind of time's marching on, but maybe just quickly, how do you think it went?
I think I need to work on how slick I am on my list of differentials as well. Um,
Mhm.
yeah, this is how I think I've done, and I'm really
Yeah.
grateful for this opportunity.
Oh, you're very welcome. And Reem, I think you did really well. Like you have all the knowledge, and you've got till October. It's just about practicing now,
Mhm.
and just getting slick at it, and just yeah, just keep practicing, and you'll find that it just falls into place
I
in
see.
time. So well done.
Thank you. Dear.
And keep practicing.
Oh, thank
Okay,
you.
so if you want to stop sharing, Reem, then
Yeah.
we'll get our candidate number two.
Yeah.
Um, Candidate number two, if you can present yourself.
Good
Where are
good
you?
evening.
Hi, hi.
Hi.
We'll do the same if that's okay with you, and
Yeah.
I'll just show you cases, and you can talk through them and you can share your screen. Okay, so again, in the chat box, there is a case. So if you just, yeah, that's the previous case, and then I've just posted in a new case.
Yeah, 1 second.
So it should be an X-ray of the knee.
Yeah.
Perfect. Excellent. So we can see that. And I will just pop my timer on.
Yeah.
30 minutes. Off you go.
Can I start?
Yes, absolutely. Go for it.
Yeah. Provided was the frontal radiograph of the left knee joint. Uh, the things there is bony outgrowths which are seen from the both tibia and femoral surfaces, and in this outgrowth I can see the continuity of the medullary cavity, and these are there are two which I can see in the tibia and two on the femur, and also on the fibula. I'd like to just see the lateral as well.
Yeah, go for it.
Yeah. So multiple outgrowth. This is seen in the posterior aspect of the femur and the along the tibia and fibula as well.
Yeah.
And there is a small fibula. So this is in keeping with multiple osteochondromatosis. I'll ask for
Yes.
the patient symptoms of any acute neurologic symptoms or
Yeah.
any, and also compare with the previous imaging for
Yes,
the study.
that's the key thing, isn't it? To compare with the previous, because usually this will be a known condition. They would have presented before and they will have had loads of x-rays. So what you want to do is you want to compare with previous to see if there's any drastic change
Yeah,
radiologically. But then also, as you say, you want to ask clinically, has there been a change? Is there new pain? Because that is another red flag. And
yeah.
even new neurology, because what are the potential complications of this condition?
One is local irritating factors, any neurovascular conflicts, and
Yes.
also if there is a sudden increase, a malignant transformation to osteochondral sarcoma is another possibility.
Yes. So tell me firstly about the those malignant transformation. Now, what is the actual percentage likelihood of that happening?
Think 10 to 20%.
No, it is really uncommon. It's like less than
Mm.
1%. Yeah.
Okay.
So in the big picture, it's unlikely, but it's something you don't want to miss, obviously. So besides the new pain and the X-ray changes, uh, what else would make you think that there's malignant transformation?
Yeah, if the patient complains of a new site swelling or
Yeah.
any fresh symptoms, that would also be
Yeah. So what would you
indicative.
ask for if that was the case? Which
Then
imaging?
for I would do an MRI to assess the cartilage
Yes. And what is the magic number for the cartilage cap?
20 to 25 mm.
I think it's 15
15. Okay.
millimeters. Yeah, yeah. So 1.5 centimeters, that's right. So if it's above that and there's been a change from before, then you're worried about malignant transformation. But as I say, it's actually very rare.
Yeah.
The more common things that are likely to cause symptoms in the patient are, as you say, so you worded it as, I can't remember how you worded it, but neurovascular mass effect, I would call it, or so
Yeah.
basically it's pressing against some nerves and that's going to cause pain. That could be one thing. Okay.
Yeah.
What else? What else could happen?
And even local bursal inflammation,
Yeah.
bursitis.
Yes, that could happen. Yeah. What
Uh,
else?
and any impingements.
Yeah, that's sort of the same thing as neural mass effect, isn't it?
Yeah.
So fracture, it can fracture,
Yeah.
can't it? It's only
Fracture.
on like a thin stalk, so that's another complication that you would talk about. So this is diphysial I mean, or the hereditary exostosis, like whichever you want to call it. And it's just like an exam favorite. They like this condition because I suppose it's quite interesting and you know there's a lot to
Yeah.
talk about. So yeah, happy to take any questions as we go. Otherwise, we'll move on to the next case.
Yes.
What is the condition again? Diphysial. Look it up. Yeah. Yeah. So if you go back to the chat box, you'll see that I've just posted another link. Can you see that?
Yeah. I'm just
Perfect.
yeah. Can you
Now,
scroll?
go for it. Yes. Abdo pain, and sometimes you'll get, something as vague as that in terms of your clinical history, but
Okay, it's just loading.
yes.
So just wait for it to load.
Yes. And this is another tip I give people, when you're in the exam setting, it's okay to give yourself 10, 20, 30 seconds for either to images to load or just for you to scroll through everything that you're given, just so that you can gather your thoughts. And then you can start talking about the most important thing rather than,
No.
because I see sometimes, people will start scrolling from the top and then they start saying, oh, spleen is normal, adrenals are normal, da 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 da, which is all true, but you're wasting time talking about normal stuff, you know? So
Yeah.
just it's okay just to say, I'm just going to take a few moments to look through the scan. That you're
Yeah.
allowed to say that in the exam, okay? Fine.
Can you start?
Yes, go for it.
Yeah. Provided of the contrast axial images of the CT abdomen. So first thing, I'm noticing multiple branching lucences in the liver, which is seen along the common bile duct course in keeping with pneumobilia. And
So how do you know it's pneumobilia and not what's the differential? What's the alternative?
so another alternative is pneumoporta,
Yes.
but I can trace the entire in along the biliary tree and radicals. So I'm
Yes.
telling that's pneumobilia. So I'll
Yes.
just crawl
And
the
also it's more
entire,
central, isn't it? It's more
yeah,
centrally
correct.
placed rather than peripheral, which would be a bit more portal veidy. So yeah, I agree with you. That's pneumobilia.
Yeah, I'll just scroll completely the set of images, and I can see there are multiple dilated small bubble loops.
Yes.
And with pneumobilia, I'm trying to see for the gallbladder,
Yes.
which up, yeah, which appears minimally distended, and there is pericholecystic fluid. The wall is
Yes.
enhancing. I can see
Yes.
there is a open communication between the gallbladder and the
Yes.
duodenum, and I can see the multiple dilated loops. I can see a circular hyperdense structure
Yeah.
with central lucency in one of the mid-jejunal loops.
Yes.
And I'll complete, and I'll in my routine imaging, I'll also see in the lung window and bone window. So this
Okay,
is
don't worry.
keeping gallstone
Yep.
ileus with small bowel obstruction and pneumobilia with the
Yes.
cholecystoduodenal fistula.
Excellent. That's exactly what it is. So what can I ask you about this condition? So if the gallstone was stuck more proximally in the duodenum, what would that condition be called? Do you know?
Um, can you repeat it again?
So this gallstone has passed
Yeah,
through from the gallbladder into the small bowel, and then it's worked its way all the way quite distally into the distal small bowel, which is
yeah,
usually how gallstone ileus does occur and present. But sometimes the gallstone will get stuck proximally right in the duodenum. It won't work its way distally.
yeah.
So, and that
Um,
causes gastric outlet obstruction. So, do you happen to know the eponymous name for that condition?
it's Merizzi syndrome.
No, syndrome is different. This is called Bouvray syndrome, as people have
Non-progressive.
put. So well done, whoever got that right. Bouvray syndrome, don't worry, it's just extra information. That's when the gallstone is too big to pass through the duodenum, so it stays in the duodenum and causes gastric outlet obstruction. But anyway, so if you saw these findings on an X-ray, this would be termed as Wriggler's triad, wouldn't it? You heard
Yes.
of that, Wriggler's triad? What is Wriggler's triad?
Wrigley triad includes pneumobilia,
Yeah,
then small bowel obstruction, and an
yeah.
obstructed ectopic gallstone.
Yes, yes, exactly that. So, let's talk about causes of small bowel obstruction. So, gallstone ileus is one, it's fairly rare, isn't it? But what are
Yeah.
the more common causes of small bowel obstruction?
Yeah. One is hernia,
Yeah,
anteroabdominal wall hernias.
yeah,
And second is any previous surgeries, adhesions.
yeah,
And other things include internal hernias,
yeah,
volvulus,
yeah,
and closed loop obstructions.
yes. And along with, you said anterior wall hernias, I'd include groin hernias in that as
Groin
well.
hernia,
Yeah, groin hernias. So
oculofemoral hernias.
you can do like if you're struggling to see what is the cause of small bowel obstruction, I would like zone into the groins and just and remember in this exam, it's a bit like it's obviously not for this case, but I'm just giving you general tips.
Yeah.
When you sit your driving test and you have to make every thing that you do very obvious so that the examiner knows that you're doing it right, even though, like looking in your mirrors or whatever, like you do it in an exaggerated way. So it's similar thing in this exam, okay? So you have to show that you're looking in all those places, and you're verbalizing what you're thinking as well. So remember to do that. So
Yeah,
because you'll get,
definitely.
even if you're not seeing the cause of small bowel obstruction, you'll get points by just saying, well, I know that one of the causes of small bowel obstruction would be groin hernias or anterior abdominal wall hernias, so I'm going to just look at those, review those, and then move on. So, if you're stuck, don't just start looking at the negatives and showing that you have knowledge about a certain condition, even though you're not getting to the diagnosis. That makes
Oh,
sense. So,
yes.
gallstone ileus. Let's show you another one. Hopefully this comes up.
Yeah.
I think,
Yeah.
yeah,
I think.
hold on a minute. Hold on. So just scroll down a little bit because I want to see which study this is.
Okay. It's just loading.
Scroll down a bit. Okay, no. Go back and look at study 2. Yeah.
Okay.
I never know which order this is going to come. Hopefully this is the one I want to show you now.
Okay.
Just scroll down. Keep scrolling. I just want to see where the contrast is, basically. Yes. Patient attends with chest pain. So, seen by A&E staff, and they think it's a PE, so they ask for a CTPA.
Okay. So provided is the CTPA study of patient with chest pain. I'll just scroll through the entire stack before I comment. It's still loading a little.
Are you sitting the exam this next time or
Yeah, in the October.
October? Okay.
So I can see the aorta is enlarged, dilated. I can see there are intimal calcifications which are medially displaced,
Yes.
and there is some thickening in the mural aspect, which however
Yeah.
I'll be seeing in the contrast series.
Yes.
And I'm just completing the entire stack of images. So the abnormality lies in the thoracic aorta
Right.
with dilatation and medialization of the intimal atheromatous calcifications.
Yes.
And also because it's a CTPA, I'm looking for pulmonary thromboembolism.
Okay.
The pulmonary artery dimensions appear normal. And I'm
Yes.
just checking for any filling defects, which I have not found.
Yes. I agree with it. There's no filling defects.
And there is no bowing of the right heart. However, there is mild contrast in the hepatic segment of inferior vena cava. So there
Yeah.
is also left mild pleural effusion.
Mm-hmm.
So I'll just
So I
have a
think you've
look.
got enough information there to tell me
So,
what you want to do next.
so I'm thinking of acute aortic syndrome
Yeah.
and intramural, probably intramural hematoma and dissection. I want to rule out. I would
Yes.
look for the
Okay. So
aortogram for further
okay.
evaluation.
So there you go. That's the first case, isn't it?
Okay. Okay. So provided of the arterial phase images. It's still loading.
Yeah, don't worry. Whilst it loads, so again, let's just talk about technique here. So
Okay.
you've seen the right thing. You've got the diagnosis there. You've seen the area of abnormality. Okay. But
Yeah.
remember in the exam that you have to really exaggerate the urgency of the finding.
Yeah.
Okay. So is this something that you need to pick up the phone and speak
Yeah,
to the
definitely.
clinician? So
Yeah,
that you need to
definitely.
say that then. You need to say that because
Mm,
um, this is like a question of patient safety, and that's the one thing that you can't fall down on. Yeah.
definitely.
And so, and I know you probably would do this, but again, this is like
Yeah,
just exaggerating everything and just making sure that you're verbalizing all your thoughts, which is so you'd say, I'm seeing this, it's an urgent finding. I'd if the patient's still on the table, I'd get the radiographers to do a CTA and I would get the clinicians on the phone and tell them I'm worried about acute aortic syndrome.
Yeah,
Yeah. So that's what you
sure,
need to say. So have
sure.
you got more images now?
Yeah, I'm just scrolling now. Okay. So I can just see periaortic hypodense collection with medialized calcification. And there is also in the intramural aspect, there is a small hyperdensity in this segment posteriorly.
Keep going down.
Also, there is a communication of this contrast through the intima and it is extending. So this is in keeping with the intramural ulcer and intramural hematoma. Yeah, I can see there is now an intimal flap as well.
Mm-hmm. So this is a little bit of example in point of, and I know you're waiting for the images to come, but
Yeah,
your diagnosis changed once you had scrolled down a little bit more. So this is a full-on dissection, isn't it? It's not
yes,
just intramural hematoma, it's a dissection. There's a dissection
mm,
flap there.
yes,
So again, allow yourself some time just for like everything to either load up or for you to look at all images before you start saying what you think it is. So this is a dissection. Now, what kind of dissection is this?
So this will come to the Stanford B type of
Yeah.
dissection.
So what kind of management does this require?
So I'll pick up the phone and inform the referring physician and get
Uh,
input from vascular surgeon and
yeah.
also inform the interventional radiologist
Yeah.
for further management.
Yeah. But what is the management of Stanford B usually?
Usually they go on conservative.
Yeah.
Yeah.
Yes. That's right. So Stanford A was ascending aorta is usually surgical. So cardiothoracics usually would be involved with that. And if it's just in the descending aorta, then it's usually conservatively managed, but obviously it depends on other factors. You can look for things like end organ ischemia
Yeah.
if you think that there's compromise to the blood
Yeah.
supply. These are just things to get
Contrast.
extra
Yeah.
points on the
Okay.
scan.
Contrast externalization.
But this is actually quite a common scenario when the patient comes, they have chest pain, and they think it's PE, and they get a CTPA, and then
Yeah.
there's no PE, and then it's always really important to look at the thoracic aorta because medialization of the intimal calcification is quite a sensitive sign for something going on in
Yeah.
the aorta, and so yeah, you'll see this often, this kind of thing. Yeah,
Yes.
good. Let's look at some more cases.
Yes.
Where are we? There you go. So I want you to have a look at this case yourself, and then you can tell me yourself how the patient's presented.
Okay. Just loading a little.
Yeah, yeah. So do you mind sharing where you work?
Yeah, I work in India.
Uh-huh. So this is like, is this the like middle of the night for you?
Yeah, correct.
Oh,
It's
well
well
done.
for yeah.
Well, I'm grateful you've stayed up for this.
Thank you.
So it's a challenge, isn't it, when you have you worked in the NHS ever?
No, I have not yet.
Yeah, yeah. So that's part of the exam, I suppose, is knowing how things work here in the system that we
Yeah.
have here. But that's why these courses will be really invaluable for you, just to like understand how things work
Yeah.
here. The pathologies will be the similar to what you have, although you'll have probably much more exciting things than what we have, TB and stuff. But
Yeah.
but the how things work is just what you have to pick up from like courses like this. Um, Okay, I think you probably have enough there.
Yeah, I'll just start.
Yes.
Provided of the axial CT non-enhanced CT images of the brain.
Mm.
Yeah, I'm just scrolling through the entire stack. Just take a moment before I comment.
Yeah, that's fine.
So at the first look, I have not found any obvious abnormality. The gray-white matter differentiation is maintained.
Mm-hmm.
This is an old patient, adult skeleton.
Yeah.
So I'm just looking at, yeah, okay, yeah. So
What do you see?
I'm just looking for the early signs of infarct.
Okay.
So I didn't find any absent lentiform sign or
Okay.
hypodensity. But when I'm tracing the basilar artery in the
Yes.
superior most, I can find it hyperdense,
Yes.
almost like the top of basilar component, which is
Yes.
hyperdense.
Yeah.
So I'm suspicious with basilar artery occlusion and an acute infarct, which may be very early for here to pick
Yes.
up. So I'll
Yes.
immediately pick up the phone
Yep.
and talk with the referring physician and ask for the history as well.
Yeah. What do you
And
think the history would be?
she would be the weakness, I feel.
I think there'd be GCS3. There'd be like,
Coming,
yeah, so they would be pretty much unconscious. I mean, the grey white
yeah,
matter is preserved, so I think maybe this is just really early that they've caught it.
yeah,
But because sometimes you see it when it's just completely grayed out, isn't it?
yeah.
And that's like quite far on.
Yeah. And
But
also
the
ask
like
for the,
typical history for basilar artery thrombus is like GCS3, presents GCS3. So then you've got to be thinking, okay, something bad has happened. And basilar artery thrombus is a diagnosis not to miss. And
yeah,
that's why, even to just always trace the arteries. I've just posted there the CTA, which just confirms it, if you just want to take a look at that as well.
okay,
Um, and so yeah, you said so again, I like that you're saying you'll pick up the phone and say this is urgent finding. That's exactly what they want to hear.
yeah,
That
sure.
you do understand the gravity of the situation and that you know you need to act fast. And then what would be the treatment for this?
So they will be lysing the clot. So
Yeah, or they
if
could go and get it. They can go and fish it out.
yeah,
They can do a thrombectomy, can't they?
go back to me, yeah,
Thrombectomy, which is what they do, what they did do for this patient, because again we're next to a thrombectomy center, which pretty much round the clock now runs their service, which is excellent because this is like one of the things that will instantly cure the patient if you just fish out that thrombus.
yeah,
So if you just once it loads up, you'll see that the where the filling defect is. So this is a basilar artery thrombus, not a diagnosis not to be missed.
yeah.
Okay, as you just go up there, you'll see it in a second. Meanwhile, I'll just get my other case.
Yeah, there is a
Just there,
complete occlusion at the
disappears,
top. Yeah,
disappears,
top,
doesn't it?
this section. Yeah,
So basilar artery thrombus, that is. Okay,
yeah, yes.
okay, there's another case for you. We've got a few minutes left, and then it will be our mystery guest who's not so mystery anymore, who'll
Okay.
be taking over with our third candidate.
Thanks.
So this should be a chest X-ray. So just alter the windowing there. So this is like a 30-year-old man who's presenting with chest pain to A&E. So he's had a
Okay.
chest X-ray. What do you think of
Okay.
it?
So, so provided is the frontal chest radiograph in an young adult with history of chest pain. I'll just take a moment to see before I comment. So the first thing I can notice is a well-defined uh, semicircular opacity, which is seen in the right paratracheal region. The lateral margins is well defined and the medial margins are obscured. There's no significant associated tracheal narrowing or medial tracheal
Yeah,
shift to the contralateral side.
good. Yeah, yeah.
both lung fields
Is it
are
just on the
clean.
right?
There is slight thickening of the left paratracheal
So
stripe and
move your mouse slightly more to the left. There. There's a rounded opacity there too,
here as well. Yeah,
isn't there? Is it part of the same thing?
it it
Hard to
can be.
say. Hard to
Yeah,
say.
it's
What kind
hard
of
to say.
differentials are you thinking?
So the first thing is it's also it is extending above the clavicles. It's a
Yes.
positive for cervicothoracic.
Yes.
So
What does
I'm
that mean?
thinking so it is not in the anterior mediastinum.
Yes. If it
So it must
becomes
be
if it becomes blurry above the clavicle, it's in the anterior mediastinum. If it's seen sharply, crisply, it's not in the anterior mediastinum. In
yeah,
mediastinum. So it's not in the anterior mediastinum. We can say that for sure.
yeah.
Um, so remember, this is a youngish chap, and he had a chest X-ray about 6 months ago that was normal, completely normal.
Okay. So the
So
differences includes for this is I can consider a thyroid lesion
possibly,
possibly, and paravertebral neurogenic lesions like schwannoma
possibly,
and also a neuroenteric cyst or
possibly,
or meningospele.
maybe. Okay,
Yeah,
here's the CT.
yeah.
Have a look at the CT.
Yes, I'll just open.
Extramedullary hematopoiesis, someone's put. Maybe. I'm not giving much away here.
Actually, first thing in this scrollable images I can
Mm,
see is right over the cutaneous and subcutaneous
yeah,
plane
yeah,
in the right in the in the midline.
yes,
This lesion has hypotense component, also some internal hypertense areas with some surrounding fat stranding.
yeah.
And predominant this lesion has cutaneous and subcutaneous centering.
Mm,
And I can rule out there is no lesion in the mediastinum.
yes. So that
Seems
that
like
you that lesion you saw in the chest X-ray is that what's causing it? This thing on the subcutaneous?
yeah, it's
It
the
is,
same.
isn't it?
It is. Yeah,
So this is an external thing. It's
yeah,
not a mediastinal mass. It's an
yeah.
external thing. It's a sebaceous cyst.
So basis is infected with secondary fat
Yes.
stranding. I can
Yes.
also see some small linear hyperdense which can be the
Yes. I think it's infected. That's right.
infected. Yeah,
So this is an interesting case, isn't it? Because
yeah,
you see the chest X-ray and you worry, you think, oh my gosh, what's happened in this 30-something-year-old? It's new-ish, 6 months ago the chest X-ray is normal. And it kind of, I had to put all these alerts on the chest X-ray report, and I even spoke to the A&E doctor who'd referred it to me. I said, look, there's something going on here. We need to get him into CT urgently. And then this is
yeah.
what it turned out to be, a cyst on the back, which they hadn't put two and two together. And if you bring the X-ray back, I think it's just the link, isn't it? The one next to it. If you bring that one back, it's seen so
Yeah,
crisply, isn't it?
true.
Because it's at the level of the top of the lungs, the lung apices. So when the X-ray beams go through it, it causes
Hmm.
the that very crisp line because you've got air around it in a way because it's at the level of the lungs.
Yeah.
The sebaceous cyst causes a silhouette with the atmosphere, and as it's a raised lesion in the
Hmm.
skin, it mimics a mediastinal mass lesion, which is what our mystery guest has
Yeah.
said, which is true. But that's what it is. So it's not. So again, sometimes thinking outside of the box. It's not
Yeah.
always a mediastinal mass. Could actually be external to the patient. Please
Yeah.
show the CT again. You can actually see the CT yourself. You can just click on that link, but if you want to just show it there. And that's our timer. Perfectly timed. Okay.
Yeah.
So how did you feel that went?
Uh, Felt okay. That management part and all had to work.
Yeah. So again, I think you did really well. I think you've got the knowledge. it's just similar to the candidate before you. It's just about becoming slick, and that just comes with practice. And certain tips, like if you just you're already doing that, which is great, with like things like, showing how urgent a situation is, saying that you'll pick up the phone and speak to clinicians, all these things you're already picking up. So I think you're doing really well. Again, it's just a matter of practice.
Thanks a
Okay.
lot.
Okay. No problem. All the best.
Thanks a lot.
So I think now if you stop sharing for me, please. So CT should not have been done. Well, technically, someone said here, technically no. I mean, they had said something in the clinically about a cyst on the back, but we weren't able to put two and two together. We didn't realize it was that big. Could we have saved irradiating the patient? Probably, but anyway, that's today's world, isn't it? Okay. So I think I'm going to bring on my mystery guest now, which is, as I said to you, not that mystery, but um, it'll be great. And I think our candidate 3, if I can just invite you as well.
Good evening, ma'am.
Hi. And mystery guest, can I announce you now? Yes, there you are. You're on mute. I don't think I need to introduce you. You need no introduction. And you're still on mute. Oh gosh, how do I unmute you?
I'll do that.
Oh, right. Yes, he's
Yeah, I'm now
unmuted.
unmuted.
Yes,
So,
I'll let you introduce
welcome.
yourself, and you need no introduction, or maybe Dr. Khan can do the introduction.
Yeah, the mystery guest remains mystery, where the legend is here, and we are very privileged that John Curtis has given us this very pleasant surprise. So, thank you very much, John. I'm sure the audience will gain a lot from you, and as they are gaining from Radhika's, excellent teaching session. So, over to you, please.
Thanks very much, Sammy. Thanks, Rad. I'm going to put the timer on, and we've got candidate 3. And
Good evening,
candidate
sir.
3, where are you from, candidate 3?
Sir, I'm from Pakistan.
And would you like to give me your name, or do you want to be known as candidate 3?
Sir, I am Dr. Umair.
Okay. And I presume it's quite late in Pakistan, is it?
Yes, sir, it's midnight almost.
Okay, well, this is going to be more of a teaching session rather than a grilling, if
Okay,
that's
sir.
okay with you.
Yes, sir.
Okay, so what I'm going to do, I'm going to give you the first case, and I want you to share the screen that you've got open with everyone else, please.
Okay, sir. Sir, I'm sharing my screen now.
Perfect. Okay, this is a female patient, 35 years of age, with a pyrexia, and she's very sick.
Okay, sir. I'm presented with a chest X-ray, a frontal projection of a slightly mature patient, and then I can appreciate that there are multiple tiny nodules diffusely scattered throughout bilateral lung fields are seen, and then there is a bilateral CP angles are sharp. No pleural effusion is noted, and now I can appreciate that the left breast is not present. Or, sir, I would like to take the history that if there is mastectomy or what. And sir, I would now examine rest of the bone.
I'll just stop you there. Now, in the exam, the examiners will help you.
Okay, sir.
I can understand why you might think there might be a mastectomy, but quite often the breasts can be asymmetrical due to technical reasons.
Okay,
And
sir.
that's the case here. So the breasts are intact.
Okay, sir.
It's a mastectomy.
Okay, sir. Okay, sir.
But
Now I
tell
would.
me what you think the nature of these nodules.
So these are basically miliary nodules.
Yeah.
And sir, in differential, sir, keeping in with the history, sir, I would first my differential would be miliary tuberculosis.
Yeah.
And if there is any history of primary, then these could represent miliary metastasis. And then if the patient is very sick, I could also think of fungal infection. But I'll
So
collate my
because
findings
the
with it.
patient's so sick, what
Yes,
do you
sir.
think the most likely diagnosis is?
So in this case, it will be some mildew tuberculosis, and I
Yeah,
will immediately inform the infectious disease department, isolate the patient, do the contact tracing, and sir, do the acid-fast bacilli, and
good. Did you notice some mild splenomegaly below the diaphragm?
yes, sir, yes, sir. There
Yeah,
is mild
good.
splenomegaly.
Okay, have a look at this next one. This is a young lady with night sweats and weight loss.
Okay, sir. Okay, sir. Okay. Okay. So I'm presented with a chest X-ray, frontal projection of a skeletally mature patient, and in this X-ray, the first obvious abnormality I can appreciate is that there is mediastinal widening noted, and then I can appreciate that there is bilateral paratracheal soft tissue opacification is seen with the lobulation seen in the aortopulmonary window as well, and widening of the right paratracheal stripe is seen as well.
Mhm.
And sir, bilateral hyla in this given projection are unremarkable. And I would now comment on rest of the bilateral lung fields, which are
Just
ghostly.
tell me what you think the diagnosis is.
Sir, there is something anterior mediastinal mass, and it could be lymphoma,
Yeah,
thymoma, or
that's exactly what it is. So if the examiner just wants you to tell them what the diagnosis is, just come out with it. Now, the reason why this is lymphoma is we've got obscuration of the aortic knuckle,
yes, sir.
or there must be a middle mediastinal mass.
Mm,
There's a right paratracheal mass lesion, which is an anterior mediastinal mass. And
mm,
then there's filling in between the pulmonary trunk and the left atrial appendage, and that is going to be in the anterior compartment. So we've
compartment.
got a mixture of anterior and middle mediastinal mass lesions. They are multiple, therefore it must be lymphoma. Yeah,
Okay, sir, yes,
yeah.
yes,
So you can eliminate pretty much everything else because you've nailed it with that description. Yeah.
thanks. Yes,
Okay, have a look at this one. This is an elderly male who has got abdominal pain.
yes, sir. Okay, sir. Okay, sir. I'm so presented with X-ray abdomen, and in which I can appreciate that there are dilated bowel loops are noted, and these are likely small bowel loops, as I can appreciate the belly belly conventives.
Yeah.
And sir, then sir, I would try to look for the cause on this provided plain film. I cannot appreciate any pneumobilia or any sir radio opaque shadow or hernial orifices also appears to be unremarkable. Sir, I have a doubt of a regular sign, which I would confirm on the lateral shoot to film if possible, or I would advise
Okay.
urgent CT
Would you
scan.
really do a lateral shoot through film, or would you go ahead and do
Sir,
CT?
if the patient is still in the X-ray, I would prefer, or otherwise, I'll urgently advise CT scan
Okay.
yeah.
Okay. So, what are the causes of small bowel dilatation? So,
Sir,
before you do the CT scan, what
yes,
kind
sir.
of diagnoses go through your mind for somebody who's got small bowel dilatation?
Sir, the most common causes are adhesions, and then followed by some hernial obstructions, and then sir, strictures and internal hernias and
Now, you're
obstruction.
talking about mechanical obstruction, yeah?
Yes, sir. Yes, sir.
Now, I would lump that into one diagnosis as one cause, okay?
Okay, sir.
So if mechanical obstruction is one cause, the
Yes,
other
sir.
cause is paralytic ileus, yeah?
Yes, sir. Non-mechanical obstruction. Yes,
And
sir.
there's another cause that we all tend to forget that gives you small bowel obstruction. Sorry, small bowel dilatation. What's that?
Sir, ischemia.
Yeah, absolutely. So
Yeah.
always think of small bowel dilatation as mechanical obstruction,
Yes.
paralytic ileus, or ischemia. Okay.
Okay, sir. Okay,
And
sir.
the reason why we do a CT scan is to work out if it's a mechanical obstruction. So what I
Okay,
want you
sir.
to do is I want you to go to the very last thumbnail
This
And
one?
yeah, and I want you to scroll through that
Okay, sir.
and tell me what you think the diagnosis is.
Okay, sir. Sir, actually, it will take time to
Yeah,
load.
while it's loading, I'm just going to ask you some questions. So,
Yes, sir.
if you do a CT scan,
Yes, sir.
what's the feature that tells you it's a mechanical obstruction?
Sir, if we do a CT scan, then the feature, sir, if there is, if we can find some cause of obstruction,
Well,
then
you may find the cause, but you may not find the cause. So, what tells you that there must be a mechanical obstruction?
so there is a transition point in case of mechanical
Yeah,
obstruction.
transition point or just a caliber change. So you may not see the transition point, but you
Yes,
see
sir.
dilated small bowel and
Yes, sir.
normal or collapsed small bowel. Yeah.
Okay,
And that means there must be a mechanical obstruction. So
okay,
you can
sir.
see here that we've got dilated small bowel
Ball, yes, sir. And
and there's pneumobilia. What does that make you
yes,
think of?
sir, if there is pneumobilia dilated ball, sir, gallstone ileus would be in my mind with
Okay.
cholecystostal
Always think
fistula.
about that. But in the
Yes, sir.
elderly people could have pneumobilia for other reasons. Yeah.
Yes, sir.
Okay,
Sir,
like a lax sphincter of body.
yeah.
So go down into the pelvis,
Mm,
and because hernias are an obvious cause of small bowel obstruction,
yes, sir.
it's a really good, useful tip to go and
Mm,
look at the groins early on
groins, yes, sir. Yes,
because you
sir.
might see the cause of the small bowel obstruction. So scroll down.
Yes, sir. I'm scrolling down and
Okay, I think the internet is not allowing you to do it that quickly, but don't worry, you take your time. In the exam, by the way, guys, if there's a technical problem like the internet's a bit slow or whatever, just stay calm. Don't worry about it. The examiner won't penalize you. You
okay,
just
sir.
got to remain calm, and there might be a bit of talk while everything's loading up. Okay, so tell me what's going on there.
Okay, sir. Sir, I'm okay, sir. Sir, I can appreciate that. Sir, just let it load. Okay, sir. Sir, there is a herniation of the bowel loop,
Yeah.
and okay, sir. It is not going in the inguinal canal, and I can see it parallel to the femoral vessels. So it's likely a femoral hernia,
Okay,
and
you are correct. There's an even more specific sign than just being parallel to the vessels. What do you think the hernia and the bowel within the hernial sac does to the femoral vein?
so it is compressing the femoral vein.
Yeah, and can you see that? It's a very nice
Yes,
example,
yes,
isn't it?
yes, sir. Yes, sir.
And
It
it
is
can
here. It
only
is
then
getting
be a
compressed.
femoral hernia that's causing the small bowel dilatation.
Yes,
Yeah. And you can see the transition point,
yes,
the,
sir. There is the transition point.
the
Uh,
efferent bowel that comes out of the
oh,
hernial sac is
yes, sir.
small or collapsed.
And sir, also the relation with the pubic tubercle, uh,
Exactly. So if it's
inferior middle to
medial
the
to the pubic tubercle,
tubercle. Yes, sir.
it could be an inguinal hernia. If it's lateral to the pubic tubercle and you've got
Ye-
the squashed femoral vein,
Yes,
it's going to be femoral hernia.
yes.
And why is it important to differentiate a femoral from an inguinal
So
hernia?
because it changes the surgical management.
Yeah. And also, any other reason?
Mm,
It's more likely to strangulate
strangulate. Yes, sir. The femoral hernias are.
because the femoral canal is
Yes,
much
sir.
narrower than the inguinal canal.
Inguinal
Okay.
canal. Yes,
Have a look at
yes.
this one. We're going to race through just so I can see some more films,
Okay, sir.
and you can see some more films rather.
Okay, sir.
Have a look at this one. This came through in May 2020 at the height of COVID-19 pandemic, and it's a young man with a dry cough and fever. And it was in the days before we had widespread testing for COVID. So there was no lateral flow or PCR tests.
Okay, sir. Sir, this is the chest X-ray frontal projection of a skeletally mature patient, and in which I can appreciate that there are airspace specifications which are predominantly noted along the bilateral upper lung zones. And sir, I'll window it a bit. Okay, so the mid and the low lung zones are unremarkable, and so there is the CP angles are sharp, and I would now take a look at the rest of the bones and the soft tissues, which are also unremarkable. And this is
Given
giving.
that story, what do you think the diagnosis might be?
Sorry, sir. If
Given the story I've just given you, what do you think the diagnosis might be?
sir, can you please repeat the history? I forgot it.
Dry cough, fever in the middle of the COVID pandemic.
Mm, sir, sir, it is giving somewhat batwing appearance. Uh,
Yeah, okay, so it's perihilar.
Very higher
Is that
batwing
typical
appearance.
of COVID?
No, sir, the COVID give peripheral
Yeah,
consolidations.
absolutely.
Yes, yes,
So, just forget about the COVID pandemic.
yes, sir.
This came through without COVID in the background. What would you call it?
Um, sir, it's say it could pulmonary edema, and
Do young men get pulmonary edema?
no, sir, with normal cardiac shadow and no.
If I said he had a dry cough, dyspnea, and a fever,
Yes, sir.
what does that make you think of? Perihilar airspace shadowing, no lymphadenopathy, no pleural effusions.
Mm, so some atypical viral pneumonia or
Well, it's an atypical pneumonia, and it's somebody who's immunocompromised. This chap was
sir,
HIV positive.
sir, BCP,
Yeah, it's
yes,
PJP or PCP.
PJV, yes, I guess.
Pneumocystis jirovecii pneumonia.
Yes.
And I'll show you the HRCT that was done. I don't think this man needed an HRCT really. He just needed a bronchoalveolar lavage with PCR of the lavage to make the diagnosis. But this was the CT, which shows shows very nicely the distribution of the
Yes,
consolidation and ground glass change.
yes, sir. Very high ground glass changes.
Is it loading?
Yes, yes, sir.
Yeah, okay.
So peripheral sparing and yes,
It
sir.
was PJP.
Yes, sir. PCB.
Okay. So you saw some sclerotic bone lesions with Radica earlier on.
Yes, sir.
Have a look at this next one. Tell me what the condition is.
Yes, sir. So, okay, sir. I'm presented with the X-ray ankle
Just tell
frontal
me what the
projection.
diagnosis is.
Sir, osteopoculosis.
Excellent.
Yes, sir.
Okay,
Benign looking bony.
next case. So this is a 75-year-old male who has hemoptysis and a cough.
Okay, sir.
Don't look at the CT, just look at the chest X-ray.
Okay, sir.
So in the exam, if the examiner tells you not to look at the chest X-ray, not to look at the CT, what are you going to do?
So sorry if
If the examiner says do not look at the CT, what are you going to do?
Sir, I will not look at it.
Oh, no. You must look at the thumbnails.
Okay. Okay.
Okay.
Okay.
Just make it look as if you're not looking at them. Okay.
Okay. Okay, sir.
It gives you added information and it just confirms what you think when you look at the chest X-ray. So tell me what you think is going on the chest X-ray.
So
Given
chest
the
X-ray
fact
frontal.
that you're having a sneaky look at the thumbnails.
Okay, sir. So this is a chest X-ray frontal projection of a skeletally mature patient in which I can appreciate that there is an ill-defined opacity with central cavitation noted in the right upper lobe,
Yeah,
and so with ill-defined speculated margins. And sir, I would quickly go through for the surrounding bones and rest of the bones. And so I can see that there is a erosion along the lateral end of the left clavicle as well. And so
good.
I would quickly look to go through the bones. So I cannot see any gross erosion in the rest of the bones.
Okay,
And
well done. You've done really well. That's perfect. So you've
okay.
picked up the lytic lesion in the outer end of the clavicle, which
Mhm.
obviously represents a metastasis. If
Yes,
you look
metastasis to the
even more closely, you'll see that there's a metastasis in the left posterior fifth rib as well. I don't know if you
yes,
can see that.
yes.
Yeah, that's it. You've no, fifth rib, higher up.
See?
Yeah, that's it. Yeah, you've got it. Okay,
Yes.
well done.
Yes.
Excellent.
Okay.
Okay, this patient has got wheezy chest and occasional dyspnea.
Okay, so okay, sir. Chest X-ray frontal projection of a skeletally mature patient, and in which I can appreciate that there are peripheral based air opacification is noted, and sir, rest of the lung fields are quickly go through rest of the lung fields, bones and soft tissues. Which are grossly unremarkable. So this is a reverse battering pattern, and
Good.
sir, in this
What does it
case, my differential
suggest?
Sir, differentials would be cryptogenic organizing pneumonia, eosinophilic pneumonia, and COVID. And
Okay, that's good.
yes, I
Next
would
case.
advise.
Well done. Next
Okay.
case, who has a slowly progressive mass lesion in his thigh.
Okay, sir. Okay. Uh,
It's okay. It's
oh,
just taking a short while to load. Look at the thumbnails 1 and 3. So if you go to the change layout, if you go to the
okay, sir.
grid, yeah, okay, that's fine.
Okay, sir. So should I start from this one, frontal?
Yeah, put them side by side if you can. So if you go to the change layout, that's it. Put them side by side. Yeah, that's fine. Perfect. That's okay. You've got it.
Okay, 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 sir. Sir, so I am provided with the multiple views of femur, and in which I can appreciate that there is. Uh, Scalping along with cortical irregularity, which is noted along the femur, and I cannot appreciate any periosteal reaction, and the knee joint is unremarkable. And so the rest of the soft tissues are slightly hyper dense, and sir, in this case, sir, my differentials could be um, some extra skeletal lesion which is causing scalping of these of the femur. So some
Yeah.
soft tissue masses. The sir, I in the differentials, sir, I would like to put neurofibromatosis or some maybe sir some hemophilic arthropathy causing
Now,
pseudotumors.
you say hemophilic arthropathy. Is there a joint problem here,
No, sir,
really?
the joint is fine, sir. Sir,
Well, it's a little bit narrowed, but
yes,
it's predominantly a bony problem, yeah?
yes, sir, yes, sir.
So it's a hemophiliac pseudotumor. And the thing about hemophiliac pseudotumors are that the hematoma is subperiosteal, and what it does, it encourages the periosteal new bone to
Yes,
form, and it's almost always perpendicular to the
okay,
long axis of the bone. And that's why you get these spiky bits of bone coming out from the long axis.
okay,
Yeah.
okay. Yes,
And there's nothing else that really looks like it. It's just one of those things that just says this is hemophiliac
yes,
pseudotumor.
sir. Yes, sir.
Well done. Okay, have a look at this.
Okay, sir.
You're doing really well. So carry on. We're going to see lots of films and there'll be lots of teaching points. Is everyone enjoying this so far? Just put some feedback in the chat. Okay, what I want you to do is I want you to go to the very last thumbnail
Yes,
where
sir.
there's gadolinium on board.
Yes, sir.
And those of you at home will have some time to have a look through all the images. But
Okay.
this particular image, the T1 with gadolinium,
Yes,
really
sir.
gives you
Post
the
controls.
diagnosis. And what I want you to do is I want you to have a look at the skull base with gadolinium.
Okay, sir. I'll scroll down and look at the skull base.
Keep going, 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 keep going. Stop.
Okay, sir. Yes, sir.
Okay, give me the big take-home features here that smashes the diagnosis out of the park.
Sir, this is sir, sir, this is some sir, neurogenic lesion with salt and pepper appearance,
Good.
and sir, I
And
would,
what's its relationship to the carotid sheath?
sir, it is between both of the, it is playing the carotid sheet between the external and internal carotid arteries,
Yeah, so
carotid
the
body tumor.
carotid
Yes, sir.
arteries have been displaced anteriorly.
Yes, sir.
Therefore, what's the diagnosis?
It's a carotid body tumor, or yes, sir.
Excellent.
Yes, sir.
Okay, that's good.
Yes, sir.
Um, okay, have a look at this next one. This is an elderly female who presents with abdo pain and vomiting.
Okay, sir. Okay, sir. Again, this is X-ray abdomen, frontal projection of a female, in which I can appreciate that small bowel loops are dilated, and so I would now take a look at rest of the bones and soft tissues. So she's
Okay,
present. So
so
this small bowel dilatation and small. I am suspecting small bowel obstruction as she's
okay,
vomiting. So I will urgently pick up the phone and call the on-call surgical unit and advise CT scan for the patient.
okay. So we'll do the CT scan and I'll show it to you.
Okay, sir.
Just go straight into the axial images. Don't worry about the scout.
Okay, sir.
So again,
Okay.
the examiner might help you by saying, ignore this image, this image, this image. Just go for that image. Yeah. And they're trying to help you. They're not trying to hinder you
Okay,
when you do
sir.
that.
So again, there is ascites, small bowel dilatation, NG tube with its tip in the normal position. And sir, while scrolling, I would take a look at the portal vein and the
Now,
mesenteric
you
vessels.
said there's ascites.
Yes,
There is a small amount of ascites.
yes, a small amount of
Yeah.
ascites.
Okay. And there are bilateral pleural effusions.
Yes,
Yeah.
sir.
Uh,
And so I will scroll till the last things.
Now, just stop there. Go higher. Go a little bit higher.
Yes, sir. Yeah.
Stop there. Now, if you saw nothing else,
Sir,
you
there is
know that it must be a mechanical obstruction
yes,
because you've got dilated small bowel and
bowel.
non-dilated small bowel. And then the
Yes,
next thing is, and I think you've got it.
yes, sir.
Tell me
So there
what.
is again, sir, there is a point of transition, and sir, there is a hernia between the obturator hernia. Uh,
Excellent. How
yes, sir.
common are obturator hernias?
Sir, very uncommon.
Yeah.
Uh,
And how likely is it that the surgeon can palpate the hernia on clinical examination?
Sir, I don't think so. It's palpable. I
It's
have,
very unlikely.
yes,
Yeah.
sir, it's very
So,
unlikely
so
because
this
of
is where
these.
radiology really is a game
Yes.
changer in this situation.
Also, so there's uncomplicated diverticulosis as well.
Yeah. Okay, have a look at the next one I've sent, which is just above the three comments.
Okay, sir.
And I just want you to describe what's going on. First of all, tell me whether it's male or female,
Okay, sir.
and tell me whether you know what the diagnosis is.
Okay, sir. By by looking at the shape of the pelvis, sir, I think it's sir, female patient, sir, because of some gynecoid
What's the opposite of female?
male.
Yeah, where'd you put the gonad shield on a male patient?
Okay, sir.
Yeah,
No, sir.
yeah. So this is a male patient. Okay.
Yeah.
Now tell me what the diagnosis is.
Okay. Um,
Okay. Describe the right femoral head and femoral neck and femoral shaft.
sir, the femoral head, sir, it's sir, the size, there is size asymmetry, and sir, as well as sir, there is asymmetry of the pelvis, and
Yeah,
so atrophy of this side of the gluteal muscles as well. So
yeah,
this is something chronic denervation,
yeah,
likely could be poliomyelitis or
yeah.
could be
That's
in,
that's
in
exactly what it is. It's polio.
yes, sir.
Um, yeah, that's good. Okay, have a look at this next one. This patient comes for a routine medical examination and has a chest X-ray on account of finding high blood pressure.
Okay, sir. Okay, such as extrafrontal projection of a skeletally mature patient, and in which I can appreciate that there is opacity noted in the left lower lung zone, and sir, then I can appreciate that it is surrounded by lungs from all side. Uh, Along with
Now,
that,
is
uh,
this lesion
yes, sir.
completely surrounded by lung, or is it well defined in some parts of the lesion?
Sir,
And in
laterally it
other
is not well
parts,
defined.
it's
Sir,
fine.
it is yes, sir. It laterally it is not well defined. It is also causing scalping of the rib as well.
So what does that suggest?
So that suggests it is likely posterior mediastinal.
Well, is it in the mediastinum? Because I can see lung between the lesion and the mediastinum.
Mm,
Not in the mediastinum, is it? What do you think about the rib?
Sir,
Do you think
there
about
is
the rib?
sir scalping and
Okay.
of the rib as
So
well.
what three structures do you know that live in the intercostal groove?
Sir, artery, nerve, vein.
Which of the three do you think this is?
So this is nerve.
Yeah, so what's the diagnosis?
Sir, neurogenic original tumor, schwannoma, neurofibroma.
Yeah, it's a schwannoma, isn't it? So it's an
Schwannoma.
intercostal schwannoma, but
Okay,
it's
sir.
not really a mediastinal mass because it's not medial enough. It's actually coming from the intercostal groove region,
Okay, sir. Okay, okay,
um,
okay.
in the um, uh, region of the rib. Okay, how do you think you did?
Sir, I think sir. Okay.
I think you did really well. I think you did really, really well. You followed my cues, which is really good.
Mhm.
The examiner is fundamentally there to help you.
Yes, sir.
And you use your wide angle lenses to confirm things on CT. You looked at the chest x-ray, you confirmed that there was a mass lesion on the thumbnails, and then you worked it all out and you picked up the lytic metastasis. Really good. No, I thought you did excellent and very well done.
Thank you, sir. Thank you so much, sir. Thank you so much. That
Okay,
was
pleasure. I think it's over to Rad.
Yes, thank you so much,
I'm
Dr.
no
Curtis.
longer a mystery guest, so
Thank you so much. And just, yeah, really want to thank you for taking time out to be the mystery guest. Everyone, I'm sure you really enjoyed it. And
I'm
yeah,
going to stay till the end. And
yeah, go for it.
I'm going to make some comments as I think appropriate.
Yes, feel
So,
free. Feel free.
I'll be with you, but I'll turn the camera
Yeah,
off.
sure.
Thanks, Brad.
So, okay, thanks. Candidate 4, are you there?
Yes, I'm here.
Perfect. Okay. Would you like to share your name, or you can just be candidate 4? It's totally
Vivek.
fine. Say that again.
Vivek.
Nick.
Vivek.
Vivek, sorry, Vivek. Vivek, where are you joining us from?
India.
India. Okay, perfect. So, again, it'll be middle of the night for you. So let's crack on so that you can get some sleep as well. So I've already pasted a case, but you know what? I'll paste it again because so many people have said thank you to Sir John. Oh, he's become a sir now. Imagine. If he was knighted. Anyway, if you just want to open up that case and then share your screen,
Yes.
and then everyone can see what you're looking at.
Oh yeah. Just a minute.
Yeah.
Is the screen visible?
No, it's not. Can't see your.
I think my the thing is the MacBook doesn't let me share because of the settings. I think it has to quit and reopen.
Quit and open. Okay.
Is it visible
you
now?
could. No, it's not. Is some message coming up? Is it saying that you can't share it? Okay. Oh no, it's doing it. There you go.
Oh yeah, okay.
Perfect. Okay. Sorry, I got distracted there. Someone called me Dame Prasad, which is hilarious. Okay. Right, off you go. We'll do half an hour again, yeah? So we'll run over a bit today, but that's okay, isn't it? Dr. Khan, I'm sure you don't mind.
Yes. So shall I start?
Yes, please, Vivek.
So this is a frontal radiograph in a skeletally mature patient. On the first look, I don't see anything grossly abnormal in this, so I'm going to go through my review areas. And the most striking abnormality which I see is that the lunate is more sclerotic than rest of the bones.
Yeah.
The scapholunate interval is normal. I do see a bit of lucency inside the lunate, but this could be projectional. Going through quickly through the rest of the bones look okay.
Yeah.
And is there another projection?
No.
So this is likely in keeping with an osteonecrosis of lunate.
Yes. Also known as.
I have it on the tip of my tongue, but I'm not what the name
Yes. Kienbock's disease.
Yeah, Kienbock's disease.
Yes. But it's okay. It's all right. That will happen in the exam, and it's natural. Don't worry. Go on.
So yeah. So the next
Kienbock's disease.
Yes, Kienbock.
It can be sometimes associated with negative ulnar variants. So when the ulnar is is it positive? No, it's negative, isn't it? This is always what confuses me because you would expect, you know what that means, don't you? So that means that the articular surface of the ulna is shorter than the radius.
Yeah.
And to me, I always think, well, why it should be the other way around, shouldn't it? So that because there may be impaction between the ulna and the lunate, but I don't know why it is negative. I don't think anyone knows the association, but there is an association. Otherwise, it's an idiopathic disease, and it can cause fragmentation, which is what you're seeing there. That lucent line you saw isn't artifactual. It's fragmentation because it's just crumbling away now, that bone.
Yeah.
Okay. Right. Okay. Have I pasted another case? I think I just did.
Oh yes. Let me open it. Sorry.
Yes. Oh, I'm so glad it worked.
Yeah.
Hopefully it just carries on working before I jinx it. So if you go back to the chat box.
Yes. Sorry, it's just that Oh yeah.
You got it?
Yep, I got it.
So are you sitting the exam this coming sitting?
Yes.
October.
Yes.
Got some time. Okay.
So
This is
shall I
CT.
Yeah,
Yeah.
it's a
So
CT.
as it loads, I'll tell you the history.
Yeah.
So this is a patient who presents to A&E,
Yeah.
and the night before he's been on a night out, and he's been caught in an altercation with someone else, and he went home. He was fine overnight. Well, he wasn't fine. He was just too drunk to know any different. And anyway, he's woken up with like horrendous abdominal pain. So if it has now loaded up, feel free to scroll through.
So I'm provided with a post-IV contrast CT abdomen images in a patient who has been in sort of a trauma.
Yes.
So I'm gonna take a scroll through before I make any comments on what's going on. Okay, so the most striking thing which I can see is that there is a small volume ascites in the abdomen.
Yeah.
I'm just gonna go through the routine areas just to see if there's any particular cause of
So where would you be thinking?
So it's intraperitoneal. So I'm gonna go through the solid organs mainly.
Yeah.
As I see, the liver is okay. The spleen,
Yes.
the kidneys, the
Yep.
pancreas, they are okay.
Yes.
So when I go to the pelvis, I do see that the bladder is a little hyperdense than the normal pattern.
Which bit do you mean?
Inside the bladder, there's a bit of
okay. I'm not too convinced about that, but talk to me about the bladder anyway.
So I do see that there's a bit of the bladder does look a bit hyperdense than the usual. Even the wall is also a bit hyperdense. Just gonna go through the ureters also quite quickly.
The ureters are fine.
Okay. So let me just look at the review areas of mesentery if I see any mesenteric fat stranding. I am not seeing any mesenteric fat stranding.
Yes, I agree with you. So basically, what you're seeing here is some fluid in the abdomen, and we're not sure in the context of trauma, and we're not sure where it's coming from. So we've ruled out the upper abdominal solid organs.
Yeah.
Now the bladder.
Yeah. So I would like to see.
I don't think it's particularly enhancing. And I don't even think the contents are
hyperdense.
So, but what I'm trying to get you to say is that bladder injuries can be occult, can't they, on the initial CT? So, what would you do next?
So first thing I would is to ask if there's a history of hematuria. Then I would look at the bone marrows to see if there's any fracture of the.
There's no fracture. But does that change your diagnosis or your differentials?
No, it still doesn't change my differential. So I would do. So there's no hematuria also for the patient, is it?
No, I don't think so.
Okay.
What can you do as a radiologist?
A delayed images is usually possible, or a CT urogram can be done.
Yes. Well, we can do delayed, can't we? We just keep them on the table for another 10-15 minutes and scan them again, which is what we did. So there's the link.
Yes. So this is the delayed images.
Yeah.
So in the delayed images, the bladder is opacified with the contrast.
Yeah.
Do see that there's intraperitoneal contrast opacification of the ascites. So this is interesting with bladder injury.
Yes. What kind of bladder injury?
It's an intraperitoneal bladder rupture. So this has to be emergency. I would call up the the referring doctor or the ED and tell them to refer this to urology.
Yeah. And how would it be managed?
It would be surgically repaired because it's
why?
Because it's intraperitoneal.
So why though?
Because of urine contamination, I guess.
Yeah, chemical peritonitis.
Yeah.
That's what. So what's the other type of bladder rupture?
in extraperitoneal.
And tell me about that.
So extraperitoneal rupture is outside the peritoneum, as the name suggests,
Yeah.
and it has a
Yeah.
molar tooth appearance around
Yes.
the bladder.
Yes.
The contrast. So
Yes. And what kind of injuries, what kind of traumas are associated with that kind of bladder rupture?
pelvic trauma.
Yeah, so usually you get the pelvic fractures, don't you? And it's usually like a road traffic accident where there's a dashboard injury.
Yeah.
So you have your knees will go against the dashboard and cause pelvic fractures, and then the pelvic fractures fragments will poke into the base of the bladder and then cause a leak from there into the extraperitoneal space, and which is why you get that molar tooth. And what's the other word for it? Molar tooth. There's another appearance which is just a flame shape. That's it. You can look like a flame, sort of. And this type though is intraperitoneal. So actually, I think you have just a couple of slices of the coronal scan there, so you can see quite nicely where that rupture is.
Yes.
So wait a second, just there.
Yeah.
That's quite neat, isn't it? Like you can just see exactly where it's gone at the dome of the bladder, and this is because it's a blunt trauma.
Yeah.
It's a blunt trauma. It's been kicked or whatever, punched in the abdomen with a full bladder, and that's caused a rupture at the top of the bladder, and then the urine is just leaking into the abdomen, and this can lead to chemical peritonitis, so the pelvic fracture is not so relevant for this particular type of rupture. But anyway, there you go. Types of bladder rupture. Here's another case.
Do they catheterize this patient, or is it only the...
Did they catheterize? No, I don't think they have they?
No, do they catheterize if the bladder is ruptured?
Once they know they've got this. It would, I don't know the answer to that. It would probably make sense to, wouldn't it? Otherwise, it'll just carry on leaking till they get him into theatre.
Yeah.
I don't know. I guess it makes sense to, yeah. Maybe we've got some urologists or ex-urologists or something in the chat, in the audience who can answer that. Oh no, I've just given the answer in the chat. Don't look at the chat box. You must have done.
Oh no, I didn't see it.
Okay. I just realized I've given the answer, but okay, in that case, don't look at the chat box, and just have a look at this. And again, you can tell me the pathology, but you can also tell me what the patient looks like, how they've presented.
So this is possibly a patient who presented with upper limb swelling and a lot of edema.
Yeah.
So
and also neck swelling and just like
swelling.
Redness, plethora of the face. That's how it's described, isn't it? Because what is it?
SVC, superior vena cava obstruction.
Exactly. Just talk me through what you're seeing.
So I see a tumor mass situated in the mediastinum, which is encasing the great vessels of the mediastinum. And there's narrowing of the right pulmonary artery. There's also non-opacification of the SVC with...
I can't see the SVC at all, right?
Yeah, with tumor extending along with possible clot also in the SVC extending to the right subclavian artery.
Where's the clot in the subclavian artery?
This one.
Oh, yeah. Well, possibly.
And
have I noticed that before? No. But I think so. What's in the right upper lobe or right apex?
So there is a tumor. There's a... should I change the window for this?
Can do, but you can see it. I mean, you can see it.
Yeah. So there's another soft tissue lesion.
Yeah.
The right upper lobe with...
I think that's the primary lung malignancy, and then the soft tissue you're seeing in the mediastinum is the associated malignant lymph nodes.
Yeah.
Right, and that's what's causing the SVCO. So what's striking about the CT is when you open it up, it's like, why is there so many collaterals in the chest wall, isn't it, and the breast? And it's because that's what happens. You get collateralization and redirection of the contrast because the SVC is blocked. So you almost know the diagnosis as soon as you did know the diagnosis because of all these collaterals. So this is SVCO, and then again showing off your clinical knowledge, like you can even tell the examiner how would they present, so all this information. Same with the bladder one. You knew all of that information, but don't wait for the examiner to ask you Like, it's your chance to show off how much knowledge you have about certain conditions. So just start talking and get as much information out there as, you know what I mean? Don't wait for them to probe you further.
Yeah. Okay.
Yeah?
Okay.
Because you know it all. Okay, here we go.
Next case.
Another one. Next case. Okay, let's see as many as you can. There you go. Fibrosing mediastinitis. No, I think it's cancer with lymph nodes.
So, shall I present? This is the frontal
Yes.
radiograph of a skeletally mature patient. Quite a few abnormalities going on in the chest X-ray. I'll just take a brief moment. The left lung field is grossly abnormal. I see multiple radiodense opacities, some of which are plurally based towards the periphery. The aortic knuckle shadow is quite enlarged, for the age, and the left breast shadow also looks quite bulkier than before, quite enlarged. There's tracheal shift towards the right side. There are also other nodules apart from the peripherally placed nodules in the lung field. Just going to adjust the window to see if the bones are normal.
The bones are normal.
So the bones are normal, and I do see that the right lung is all. I don't see any abnormality in the right lung.
Okay.
So this coming to when I see if I go on describing, I can't see the heart border very clearly. I can't see the left hilum, nor can I see the diaphragm very clearly.
Okay.
So I'm thinking the left breast is enlarged, possibly a left breast malignancy with multiple mets on the lungs.
So let's take a step back.
Yeah.
Okay. You're right. The left breast does look more prominent, more dense than the right breast, but that is because of composite shadowing.
Yeah, okay.
It's not the breast tissue, because have you ever seen like a unilateral dense breast like that? It's not a thing unless they've got a prosthesis or an implant. Yeah. So it's not a breast lesion. This is a lung, and it's actually plural because you can see encasing this lobulated. This is how I describe it: lobulated soft tissue, plural based, encasing the mediastinal and plural surfaces. Yeah. So medially and laterally is what I'm trying to say.
So the second diagnosis
lateral, and it's unilateral. So this can only be one thing, really.
Yeah, mesothelioma is my
mesothelioma. Mesothelioma, that's right. Now, could breast mets lead to this appearance? You can get pleural mets with breast malignancy, but it would be quite rare to get it quite so unilateral, I would say. This is like a very typical like encasement, pleural encasement of the hemithorax. So your first differential should always be mesothelioma. What is slightly unusual about this is that this is a woman, because traditionally, it's usually mesothelioma, like it's asbestos, obviously, so which is occupational exposure kind of thing, which in the older generation would be the male population. So it is slightly unusual why it's this lady. I don't know if it was through her occupation, or I think John Curtis has a case of a lady who presents with mesothelioma because her husband worked in some asbestos something, and she used to wash his clothes, something like that. So that's how she got her exposure. I don't know actually this particular patient how she got it. It might be her own occupational exposure. But the other things you want to look at now, you could say to get extra points. So I would be looking for other features of asbestos exposure. So I'm looking for calcified pleural plaques. I'm looking for signs of fibrosis. Those are kind of, showing that you're thinking clinically about this patient as well.
Yeah.
Makes sense? Mesothelioma, this is. Okay, another case. So do you say you train in India?
Yes.
Do you see mesothelioma?
we don't have a lot of mesothelioma, but
Yeah.
I've seen quite a few more breast.
Yeah. Yeah. So I would say maybe then again that's like an example of a condition you probably you need to read up for exams because you probably don't have that much personal experience of it in your workplace. Because certain generation of adults here above a certain age you will get mesothelioma like fairly commonly.
Uh-huh.
Yeah. Okay. Go on. What's this one?
So this is a post IV contrast in a adult patient, I guess. So I'll just take a quick look at the
Yes.
before I
I'm
make.
not going to tell you much about this patient. I want you to just work it out. Just because I'm being a bit cruel. I'm not. It's just I don't want to give it away. I want you to work it out.
So I see multiple hypodense lesions in the liver. Both the kidneys are shrunken and contract. I think.
Where are they though?
I can't see the right kidney.
And the left?
Left kidney is very shrunken and contracted.
Where? Is that a kidney?
That's the adrenal, and that is possibly the kidney.
No.
That's a lymph node then. Okay. I can't see the kidney, and there's a transplant kidney in the left iliac fossa.
Yes.
I do see a heterogeneous mass lesion, which is.
Let me stop you there. Would you call it heterogeneous? I think it's the opposite of heterogeneous. It's quite uniform.
Yeah, which is encasing. I was. Oh yeah. Okay, it's quite uniform mass in the pelvis, which is encasing the rectum.
Yes.
And this is extending to the sigmoid colon, at least the proximal sigmoid colon.
Yes.
This is not causing any bowel obstruction.
Good.
I am looking for any adjacent lymph nodes. I don't see any adjacent lymph nodes per se. There are some fat stranding surrounding it.
Yeah. So what pathologies have you seen? There's several things, right?
Yes.
So can you put them all together?
So yes. So I think the patient had polycystic kidney disease and had a renal transplant.
Yeah.
And because of the renal transplant, he was on immunosuppression.
Yeah.
And this is a lymphoma which has happened. Possibly.
Excellent.
And
excellent. What about the liver thing? That's the only thing you've not mentioned.
That's the cysts in the liver because of the polycystic kidney.
Yes. So have you seen this case before?
No.
Excellent then. Because some people sometimes when I teach on radiology masters, I use this case because it's one of my favorites.
Yeah.
And you did an excellent job here because I've not really had to prompt you or guide you with this. This is like an example of a case in which there's many findings and that can be quite overwhelming, but they're actually all connected and you worked it out. Excellent. So you notice, first of all, they don't have kidneys. So when a patient has a renal transplant and it's because of like chronic renal failure, they don't usually take out the native kidneys, do they? They'll just leave them in. They'll just leave them in, won't they?
Yes.
But this patient must have a disease which affects both kidneys and which necessitates them to be resected.
Yeah.
There's only very few things really that could be the cause of like the kidney disease. So polycystic kidney disease is one because obviously they get very big, the mass effect from them. They can be also like hemorrhage. They can also be malignant transformation, I believe. So they just took them out. So but then that explains why they have cysts in the liver then, because again, someone put that in the chat box. They said, "Oh, liver mets." Well, no, it's not actually, because again, you'll know that in polycystic kidney disease, it's not just the kidneys that are affected. You can get pancreatic cysts, you can get liver cysts. So that's what they are. They're liver cysts, and the renal transplant proves that they've had a renal transplant there, and then you'll know clinically that they'll be put on a whole host of quite strong medications, one of them which will be immunosuppressants, and that can lead to increased rates of lymphoma, and that's what that thing is in the rectum, because it has a very uniform kind of exophytic appearance. It doesn't grow in like an adenocarcinoma causing obstruction. It kind of grows out, and it's massive, isn't it? So this is PTLD, and you did really well with that case. Excellent. Right. I think we've got time for more. Let's show you some exciting stuff. Show you that one, I suppose. Yep. I'm glad other people find my cases interesting, not just me. Now, there's loads of images here, isn't there? So why don't you go to the lumbar spine and the, yeah, you could look at the GAD.
Okay.
GAD. Do you have a stir there? You have a stir there, there. Yeah.
Yes.
So what's your experience with MR spine imaging?
Okay, I'm
comfortable. Yeah. So stir imaging, tell me about stir imaging.
So stir is a fat suppressed sequence where you suppress the bone marrows.
Yes, yeah.
So anything.
Yeah, so any fat is suppressed, right? So what is bright is what?
Usually water, which is bright.
Yeah, any fluid. Fluid. Yeah, fluid. Right. So go on, tell me what you think is going on here.
So the spine looks quite abnormal. So the L3 and L2 vertebral body shows stir hyperintensity with partial collapse of the L2 vertebral body. The adjacent disc space is also involved. There's a bit of hyperintensity within the disc space, which is extending posteriorly and into the prevertebral space. This is causing severe compression of the caudate vena, which I would confirm on my axial images. And I would also, so this is also extending to the neural foramen, the adjacent neural foramen bilaterally, the inflammatory process, the stir hyperintense process, which is extending to the prevertebral. So I could look at the T2 axials through the images. That's okay.
Yeah, go for it. Yeah.
Sorry. So yes, the T2 axial images confirms the finding that there is extension to the adjacent psoas and prevertebral and epidural space, and also to the severe narrowing of the caudate. There is also narrowing and compression.
Yeah. So talk to me about the psoas muscles.
So in the psoas muscle, I see T2 hyperintense, mixed hyperintense signal within the psoas muscle.
Yes. So this is actually a good example on the axials. So if you maybe bring up the pre and post GAD of the axials, hopefully I can illustrate what I'm trying to illustrate. Is that the post?
Yeah, I think that's.
And then bring the pre. So pre and post imaging is always got to be T1, and what you're looking for is is that definitely the T1 pre? Yeah. What you're looking for is any increased signal, which will show you that there's contrast enhancement. So you'd agree that there's contrast enhancement in both psoas muscles, but do you agree that in the left psoas muscle it's more uniform, and in the right psoas muscle there's like central non-enhancement because that's necrosis and that is a abscess. Whereas on the right it's phlegmon. Phlegmon is just inflammation with no sort of capsule and no central necrosis. Abscess is like, a collection encapsulated with central necrosis. So actually that slice shows you quite nicely.
Yeah.
And does it make a difference to treatment? I suppose abscess is more difficult to get on top of because it's like capsulated. And I imagine you could probably drain that better than the phlegmon because phlegmon is just like diffuse edema kind of thing. So the diagnosis here is what?
Spondylodiscitis, possibly tuberculosis.
Yes. So possibly TB, do you say? So you'll be able to tell me actually. So what are the like more kind of hallmark features of TB discitis?
So I kind of get this mixed up. I keep forgetting if TB involves the disc or if bacterial involves the disc.
Yeah, so it's usually more actually bone based, like TB. And I imagine, like, you're based in India, I imagine you see a lot of this. We don't see that much of this here, but I have a few cases. But so what I know of it is that it's usually like consecutive thoracic vertebrae, and it's more the bone that you'll get the edema in, and the disc sometimes is spared, and then you get these big paravertebral abscesses and lesions, and they can track all the way up and down the spine and even into the neck. And spondylodiscitis bacterial is more like single discs, more based on the discs, not the bone, more in the lumbar spine, without the big paravertebral abscesses. That's my understanding of it. And phlegmon left and abscess right. That's right. Sorry, I might have got the left and right mixed up, as someone's just said in the chat. So that's right. Abscess is on the right. Fine. Okay. So this is discitis. This is bacterial, this one. But they might ask you about TB. Let's look at another one. We've got some time, I think. Yes, try that. Yes, this is a nice one. So bring up the stairs. And again, I'll just keep quiet and you tell me what you think.
Yeah, so so I'm provided with the stir images. So the abnormality which I can see is that there's a failed transplant kidney on the right and another transplant kidney on the left, which looks normal in the stir sequence. I see multiple hyperintense areas in the femoral head region. Looking at the pelvic bone, maybe there's a bit of stir hyperintensity in the pelvic bone also. These in the femoral head, these are very geographic in nature.
Yes.
So
that's a buzz term, isn't it?
yes.
So what does that mean?
It's due to a vascular necrosis,
Yes.
bone infarcts.
Exactly. So why do they have the AVN?
Because they'll be on steroids and
yes.
They'll have that because of steroids. It's prone for these kind of problems.
Excellent. Yes. So again, this is one of those cases in which you can get all the answers off these sequences, right? So some people only just notice the AVN, bilateral AVN, but they don't go that step further to understand the cause of it, because they see those kidneys and they think, oh, they're just normal kidneys, but of course they're too far down, aren't they, to be native kidneys? So one of them is a failed transplant and the other one is the new transplant. Does that make sense?
Yeah.
And that's why they've got avascular necrosis. And then you've got that typical serpiginous double line sign in the articular weight-bearing parts of the femoral heads. And you've even got, like, further on, later on in AVN, you can get collapse of the femoral head. And I think you're getting that, aren't you, on the left side?
Mm-hmm.
And then you've got a bit of effusion, you've got an iliopsoas bursal distension, which you'll just see if you go that way. Yeah, that as well, which is probably just associated with all the degeneration going on there. So that's AVN, and you know the cause of it as well, just based on that scan. So that is our 30 minutes done. So Vivek, wasn't it?
Yes.
How did you feel that went? What's in the shafts? I think, just in answering this question, sorry, I think that's just ignore that, basically. I don't think it's relevant or significant. Yeah. Vivek, how do you think it went? Quickly.
Okay, it was not bad. Better than I expected it to go.
Yeah. Again, I've been really impressed with you and all the other candidates this evening. I think all of you have excellent knowledge. For all of you, same advice, really. Just keep practicing and just getting slick, and I'm sure you'll be absolutely fine by the time it comes to the exam. So just wanted to thank everyone for staying on and joining us from wherever you're joining, even if it's the middle of the night. I really appreciate it, and hope you enjoyed it and hope you got something out of it. And again, thank you so much, Dr. Khan, for inviting me. And over to you.